Greetings, everyone, and welcome to another lecture of Mac Medicine. Today's topic is lung and pleural cancers. Now, lung cancer is the second most common cause of death in the whole world after cardiac disease. Also, lung cancer in itself is very lethal because it's the most killer type of cancer. And the diagnosis of lung cancer usually in the metastatic stage. More than 50%, more than 55% of the cases, they're diagnosed in the stage 4 metastatic disease. So it has poor prognosis. Types of lung cancer. Now we're going to talk about 4 types. The most common type is the adenocarcinoma. After that, with 25%, is the squamous cell carcinoma. The most dangerous one out of these is the small cell lung cancer. It's unresectable cancer. You need to know that. It presents 15% of lung cancers. And then we have the large cell carcinoma, which presents only 5%. All right. Now, in terms of the location of these cancers, they all can be central. As you can see, they all can be central, but the adenocarcinoma and the large cell carcinoma, they can be peripheral as well. All right. Now, we all know that smoking is the most common risk factor for lung cancer, but can these lung cancers occur in non-smokers? Yes. Adenocarcinoma is associated with, or they can present in non-smokers. Even through all his life, never smoked, all right? Not even one cigarette in his life, okay? With family history, yes, they can present with adenocarcinoma. And then with the imaging, we all know that you can see a mass, you can see a pulmonary nodule, but can lung cancer present as ground glass opacity? Yes, adenocarcinoma can present as sometimes as ground glass opacity, but not the other ones. All right. The associations, especially when we talk about lung cancer, always they're going to ask about the paraneoplastic syndromes. We should know these associations. I mean, we all know the clubbing that can occur with adenocarcinoma, hypertrophic osteoarthropathy, squamous cell carcinoma, they present with cavitations. They are usually associated with hypercalcemia. Now, this is not specific for squamous cell carcinoma, but it's the most common association. All right, most commonly the humoral hypercalcemia of malignancy, they occur usually with squamous cell carcinoma, but I mean they can occur in the others as well. For small cell lung cancer, we can talk about the syndrome of inappropriate antidiuretic hormone release, the higher adenopathy, Cushing's syndrome, Lambert-Eaton, and anti-Hu syndrome. And then the large cell carcinoma, they can present with gynecomastia. Risk factors: smoking, still number one. Aging as well. Non-smokers lung cancer can occur, as we said, in adenocarcinoma, all right, with family history. Exposures, the asbestosis, we talked about this in the occupational lung diseases, and we said that asbestosis in itself is likely to present with lung cancer, but rarely can also lead to mesothelioma. Now, in mesothelioma itself, we'll talk about this later at the end of this lecture, is specifically because of asbestosis, all right? But asbestosis can lead to lung cancer more than mesothelioma, all right? Other exposures like radon, nickel, beryllium, they all carcinogenic, all right? COPD, idiopathic pulmonary fibrosis, they are carcinogenic as well. Staging is very important. When we talk about the prognosis, it's due to the staging. Like if the patient presents in early stage, like 1, 2. Now, the TNM system, we all know about this. We're not gonna go into this because they updated the guidelines and the new TNM staging system. It's really big and complicated. We're gonna just make it simple as like localized, extensive, or metastatic. As you can see, stage 4 metastatic disease is the most common one. 55% of the lung cancers, they present with this stage, and it's very poor prognosis. Stage 3 extensive localized disease, still within the chest. It presents 25%, and then the small minority, the last one, they can be from stage 1 to 2. These the ones that are localized. These the ones that are resectable. They can do surgery with these. And then we have some terms like limited and extensive, usually used in the small cell lung cancer. Limited usually means it's confined to ipsilateral hemithorax, all right, on one side of the thorax, and then the extensive one that's metastatic. In general, like in total, like in lung cancers, 5-year survival is 20%. This is much less with when the staging is higher. For example, stage 4 is probably less. Small lung cancer also usually will have less 5-year survival. The clinical picture, it's non-specific. The patient can be asymptomatic. They can present with dyspnea, cough, weight loss, hemoptysis, chest pain. Syndromes associated like Horner syndrome, ipsilateral ptosis, meiosis, anhydrosis of enophthalmos. We all know this is associated with Pancoast tumor. It's a type of non-small cell lung cancer. Now, this non-small cell means the other ones, the adenocarcinoma and the squamous cell carcinoma. It's when this tumor located in the superior sulcus that it compresses the cervical sympathetic nerves and the brachial plexus, leading to severe localized pain, all right, in the upper limbs and the axilla, and atrophy, sometimes with facial swelling. Treatment usually with induction chemo radiation, followed by resection if localized. We'll talk about this later. Superior vena cava syndrome, it's facial plethora, distended neck veins, shortness of breath because of the compression of the tumor on the superior vena cava, which blocks the flow to the right atrium. So it's more congested in the upper parts, like the head, the neck, the upper extremities, as we said. Paraneoplastic syndrome. These are the questions. This is where the money goes. All right. SIDH. Now, the first 4 ones we said they're like SIDH, Cushing's, Lambert-Eaton, anti-Hu, encephalitis in general. They're associated with small cell lung cancer. All right. Now, paraneoplastic means this lung cancer produces a hormone. All right. We know that hormones they produce from glands. All right. Now, sometimes they can be produced from cancer cells. Now, this is usually referred to ectopic release of this hormone. For example, ADH, vasopressin. It's released from the posterior pituitary, but it can also from small cell lung cancer. Usually the patient will present with hyponatremia. You see hyponatremia. Cushing's, increased ACTH, increased steroids. This is usually associated with poor prognosis. It means this patient is on high steroids. It means this patient is immune compromised. It means he's gonna have really bad infections, those associated with immune compromised patients, like the ones you see in HIV, for example. Lambert-Eaton, it's the release of antibodies against the voltage-gated calcium channels. You see the proximal weakness. It gets better with effort. Now, this is not to confuse with myasthenia gravis. Myasthenia gravis gets worse with effort. It starts in the eyes, all right, in the ocular muscles. It's associated with thymoma. Myasthenia gravis is associated with thymoma, not squamous cell lung cancer. The one is associated with small cell lung cancer is Lambert-Eaton. Now, these antibodies in myasthenia gravis, it's against the nicotinic acetylcholine receptors. But in Lambert-Eaton, it's against the voltage-gated calcium channels. Sometimes they ask these questions. Encephalitis or anti-Hu antibodies. The patient can present with neurogenic symptoms like seizures, confusion, diplopia, ataxia, or psychiatric symptoms or neuropsychiatric symptoms together with an anxiety, depression, and loss of memory. All right. Hypercalcemia due to the release of parathyroid hormone related protein. Okay, associated with small squamous cell carcinoma. Now, squamous cell carcinoma, as we said, it's not specific for this cancer. Hypercalcemia is not specific in this one. It can present with any type of lung cancer, but mostly with squamous cell carcinoma. Hypertrophic osteoarthropathy in adenocarcinomas, clubbing of fingers, as we said, swelling in painful joints and bones. Investigations like any lung cancer, we do chest CT, PET CT for staging, and we picture up the abdomen and we see if there's liver or adrenal metastasis. Now, tissue biopsy is very important. You get the bronchoscopy, EBUS, ultrasound guided bronchoscopy, right, to diagnose, also to stage for the TNM. You have to stage the mediastinal staging for lymph nodes. And also the immune therapy. We're going to talk about this at the end of this lecture. The immune therapy has become new in the treatment of lung cancers. So you need enough tissues and to determine the eligibility for trial and with these treatments. We look for metastases with MRIing the brain. With PET CT also is better than bone scan for bones. And as we said, we look for other on the other lungs, mediastinum and liver and adrenals. All right. Management. We're gonna make it simple for the sake of the exams. In non-small cell lung cancer and small lung cancer. Now, small lung cancer will be treated as higher staging. All right. We'll talk about this later. Now, for non-small cell lung cancer, the adenocarcinoma and squamous cell carcinoma, if it's in the early stage, if it's localized, you usually do fine with lobectomy, or if you cannot do surgery in this patient, maybe stereotactic radiation. If surgery is not applicable, if it's in stage 1B still, you can do surgical resection, maybe with chemotherapy. So still surgery in stage 2 as well. Stage 3, here where comes the more multimodality treatment. Chemo, radiation, followed by surgery. All right. And now in the new guidelines, you can also start immune therapy. In immune therapy, we started from stage 3. And then we have stage 3B, also the limited staging of small cell lung cancer. We do chemo radiation. There's no point in doing surgery in these patients because it's already extensive disease and it's metastatic in stage 4, all right, or extensive. So only systemic chemotherapy with immune therapy. So when do you do prophylactic cranial radiation? We do it in small cell lung cancer if it's responsive to treatment. Okay. Post-resection adjuvant chemotherapy, whenever you do it in non-small cell lung cancer, right? After surgery, you do adjuvant chemotherapy. In the management of solitary brain metastasis, we do excision and radiation. The treatment of multiple brain metastases is through whole brain radiation plus glucocorticoids. In poor performance status patients, we do chemo for small cell lung cancer because this is an extensive disease, an extensive type of lung cancer, but we cannot do that for those of non-small cell lung cancer because we know the side effects of chemo radiation maybe is not worth it. All right, in those ones, but for the more severe one, the small cell, maybe it's worth it. The palliative treatment, pain management with radiation to the bones, maybe treatment of nausea, hemoptysis, depression management, airway obstruction management, pleural effusion. We will talk about this in the pleural effusion lecture, how to manage these. Now, as we said, again, surgery is in the only localized early stages from 1 to 2B maybe. Is not applicable if it's bilateral, if it's metastatic, it's malignant with malignant pleural effusions, if it's hitting the heart, the carina, the aorta, the vena cava. All right. Chemotherapy, now it's cisplatin based. All right, this is the preferred type of chemotherapy. All right, usually it's a combination therapy, usually 2 or 3. Cisplatin, you have to check the renal function. It's contraindicated in renal insufficiency. Maybe use other ones like carboplatin. It's individualized based on the molecular features. As we say, as we talk in adenocarcinoma specifically, there are some genomic types, some mutations that maybe with the use of specific, all right, chemo therapy targeted at this gene will help these patients. Now, this is about like these genes, they present about 25% of the whole adenocarcinoma. Now, adenocarcinoma, as we said, it's already 50%, and more of these gene mutations are discovered recently. So there'll be more role to this in the future. All right. Usually they're not asking the exams, but maybe this one is old enough to ask. The EGFR mutation, Rolatinib is the best choice. Is the best targeted chemotherapy for this gene mutation. Immune therapy. Now this is the new one. These are the better choices because immune therapy now it's for the patient it's better. Why? Because its side effects are much less, are tolerable to the patient, with only diarrhea, rash, pruritus usually, sometimes infusion site reaction, rarely inflammations like pneumonitis maybe. The idea that our T cells usually do the job to clear and scout for malignant cells, but somehow for not obvious lesion, we don't know why in cancers this mechanism, this checking, these checkpoints, they are functioning to stop this scouting for these malignancies. So we're gonna use the checkpoint inhibitors in non-small cell lung cancer. All right, starting from stage 3, as we said. So these antibodies to block the inhibitory receptors, the checkpoints. These checkpoints they inhibit the checking of the malignant cells. All right, as we said, the T cells are the ones responsible for that. Like the programmed death one, the programmed death ligand one, all right, and the T lymphocyte A4 also as well, with these molecular immunotherapies. Now, what's pseudoprogression? Sometimes with immune therapy, the cancer with imaging might look a little bit bigger. Maybe you suspect this is worsening of the cancer. It's getting bigger, but it's sometimes referred to pseudoprogression. With immune therapy, sometimes the immune attack on these cells will lead to recruitment of more T cells that will make it look a little bit bigger at the beginning of the treatment with immune therapy, but then it will get much better. So we're done with lung cancers, and we're talking now about mesothelioma. Now, this is a very rare cancer. All right, it's specifically mostly due to asbestosis. Asbestosis exposure maybe 15 years ago, maybe 30, maybe 40 years ago. You have to check for past history and exposure to asbestosis, especially like workers, occupational ones, the ones they're working with buildings, with construction, with shipyards. Smoking is not related to mesothelioma. Same non-specific symptoms, mostly pleural, sometimes peritoneal. All right, doesn't have to be to the pleura. Rarely to the brain metastasis. Usually, you can say that there is no brain metastasis in mesothelioma. There is no point in prophylaxis or any kind of that. They present as small nodules, blacks, or extensive pleural sheets. On chest X-ray, you see an unilateral pleural effusion. You do the CT, PET, CT. Thoracentesis, usually negative, as we will talk about in the pleural effusions. Is the first one. The first thoracentesis is usually low sensitivity. The second one might be better. The third one is even better, but it's still low, not enough. And if it's negative, you proceed to the biopsy. You do the closed biopsy. You do the VATS, video assisted thoracic surgery. You take a bunch of that mesothelioma and you look it up in the pathology. To treatment, usually chemoradiation. The best chemotherapy regimen for mesothelioma is bimetrexate and cisplatin or carboplatin if there is renal insufficiency. resection and radical burectomy in some cases. Of course, if it's localized, the prognosis for mesothelioma is very bad. Thank you for listening. Don't forget to subscribe for more content and hit the alarms to get notifications. Thanks again.